So first of all, I want to go over the difference between an irritant versus a vesicant. So an irritant is an agent that is capable of causing pain, swelling, venous irritation, and chemical phlebitis at the injection site. And some examples of that can be calcium gluconate, digoxin, erythromycin, gentamicin. A vesicant is an agent that causes tissue destruction, blistering, leading to tissue necrosis and sloughing. So then kind of going difference between infiltration and extravasation. So infiltration is administration of a non-vesicant or a fluid into the surrounding tissue. So when the fluid actually leaks into surrounding tissue. And the difference is when extravasation or an infiltration can become extravasation. So an extravasation is when an administration of a vesicant into the surrounding tissue. And ultimately, when the infiltration leads to tissue damage, that's when extravasation occurs. And some common agents that can typically associate with extravasation are acidic, alkaline, hyperosmolar, vasoactive, and cytotoxic medications. They have the increased capacity to cause tissue destruction and damage. And here, going over some symptoms that you might normally see with extravasation. So you might notice patient indicating pain, might be immediate or late onset. You might have a blistering or ulceration, and that can also occur between days and weeks. You'll also have some swelling and inflammation. The skin will be blanched, and it also may feel cold to touch. The patient might also indicate pressure, swelling. The patient might indicate it might feel tight. Discomfort, pain, and tenderness. Yeah, you have edema or redness at the insertion site. You might have alterations to the IV flow. So your syringe, you might feel some syringe plunger resistance or decreased flow in the IV site, and ultimately leakage of infused fluid at the insertion site. And so these are some common pictures where you can notice distinctly the extravasation occurring. So here you'll notice some blistering on the bottom left-hand picture. So it's a blistering, some obvious blistering here. So here you notice some redness and tissue damage. The top left-hand corner you'll see another areas of obvious blistering, and then the bottom right-hand corner you'll see some also areas of tissue necrosis and damage. And so some measures you might see to prevent extravasation from occurring, or some possible methods to prevent it. So you might want to avoid repeated use of the same vein or venipuncture site. You also probably want to avoid inserting an IV line into mobile areas like elbows, wrists, and knees. Appropriate dilution of medications, so make sure everything is properly diluted to the proper proportions. You want to have active comparison of extremities, so of the location where the IV site is located, and also compare it to the non-IV site, just to make sure that there's no difference in extremities. You want to assess for the IV side, make sure it's not doesn't feel cold to touch. And if you do apply tape to an IV line, you want to make sure it's loosely applied to make sure you promote circulation. So as far as dextrose, you want to make sure you limit peripheral dextrose infusion to 12.5%. And you also want to assess the catheter site hourly. So you want to assess for redness, swelling, blanching, tenderness, or leakage of the fluid. And so why is this relevant to us? So in this case, we're kind of more focusing on the pediatric population. So in the pediatric population of neonates, you notice the extravasation percentage occurs typically from 11 to 28% in children, and 22% in neonates. And some common risk factors you'll see for extravasation occurring is preterm infants, neonates, ICU patients, comorbidities that might have diabetes or circulatory disorders, and obesity. Also, the inability to verbally communicate pain in patients. So you see maybe 3 of the 4 risk factors are associated with children and infants. So it's why important to our current topic area. So as far as treating the occurrence of extravasation, you want to treat any possible instances of extravasation urgently, because more time of tissue damage, more time the extravasation is occurring leads to more tissue damage. So once extravasation is noticed, the first thing you do is you want to immediately stop the infusion. You want to leave the needle in place because you might be using that IV catheter site for the administration of the antidote of the extravasation. Typically, you want to use a 3 ml syringe, and you want to aspirate as much of the medication as possible. One thing you really want to do is you want to avoid applying the pressure to the area. There's some case reports where physicians have attempted to massage the area and actually leading to more tissue damage or necrosis, because they're actually massaging more of the vesicant into the tissue. So you want to avoid applying pressure to the area. So after you want to identify the proper antidote for the extravasation. You want to remove the initial extravasation site and needle and catheter once you identify if you need to use that site for administration of antidote or not. You want to mark the perimeter of the affected area with an indelible pin because you want to identify if the extravasation site is growing or tissue damage is growing, or if it's actually healing. You can cover the site with transparent dressing. You also want to elevate the area to minimize swelling. And so you can apply your cool or warm compress to the site. One thing again here, you do not want to apply the compress directly to the skin. So here we have some common antidotes used to treat extravasation. So mainly I'm going to go over some of the drugs here. So there's dextrosazone, and that as far as time frame, it can be used for up to 6 hours post extravasation. And some key monitoring aspects, you want to monitor your CBC, liver enzymes, and serum creatinine. Hyaluronidase is probably one of the more common antidotes you'll see used here for extravasation. It's most effective for up to 1 hour post extravasation. So that for monitoring, you mainly want to monitor that the swelling is usually significantly decreased in 15 to 30 minutes. It's usually quick acting, so you should see results pretty quickly with this antidote. Just another side note with hyaluronidase, this is a subcutaneous injection. DMSO or dimethyl sulfoxide, it's most effective within 10 to 20 minutes of extravasation, but this is more of a topical agent used to treat extravasation. A couple of other agents here, we have phentolamine, that's used for up to 12 hours post extravasation. This is an alpha adrenergic blocker, so it's basically a vasodilator. With IV administration, you want to monitor for hypotension since it is a vasodilator, so you want to monitor for the occurrence of hypotension. Another agent we have is sodium thiosulfate. You want to monitor the site for blisters in skin, salting, and increased swelling. So basically, you want to monitor that you have improvement in the occurrence of extravasation with this agent. So here's some of the pharmacological agents. Like I said, you mainly use hyaluronidase is probably more the common agent we're going to be using in the setting of extravasation. Typically, also here at Hendrick Hospital, the agent's most likely going to be used. It's on our formulary here, and you can see it treats the common agents that are typically associated with extravasation. You can use hyaluronidase as an antidote here for this treatment. See a lot of the common agents we use here. We use hypertonic saline, several antibiotics, potassium. So several agents that we use in the hospital that are associated with extravasation would be using hyaluronidase. Another agent we have on our formula here at Hendrick Hospital is phentolamine. You might also see it used here in this setting, but more typically, like I said again, it's hyaluronidase, which we're going to typically be using. So as far as the dosing of hyaluronidase, you're going to prepare the preparation of you want to dilute 0.1 mLs of the vials. That's 150 units per ml. You want to dilute it with 0.9 milliliters of normal saline, and it's going to make a concentration of 15 units per ml. So as far as administering the antidote, once the IV is in place, you want to pull back slightly as to make it even with the subcutaneous clean, and you want to inject 1 ml of the 15 unit ml solution, and then you remove the catheter. If the catheter has already been removed, you want to use a 25 gauge needle and inject 0.2 mLs of the solution subcutaneously in each of the 4 quadrants of the lesion. Alright, so I'm going to kind of go into, that's kind of the main treatment extravasation that I went over. So kind of going to go over a new area of study or a new article I recently came across. So this study was focusing on contrast extravasation using power injectors for contrast, and has computed tomography in children. And it was examining the frequency and injury severity. So this study was a retrospective study of 2,429 patients where contrast-enhanced CT with a power injector was performed. Recently, the power injector have been used to improve iodinated contrast delivery and computed topography. So early studies reported the incidence of extravasation with power injectors between 0.1 and 0.9%. And so the purpose of the study was to evaluate safety of power injections related to extravasation in children. So like I said again, a method, so this was a retrospective study of patients 0 to 18 years of age who had undergone intravenous contrast-enhanced CT examination. So going over the results of the study, in total, 18 contrast extravasation cases were confirmed for an overall prevalence of 0.7%. For patients that, in cases where extravasation did occur, the mean age was 11.2 years of age with a p-value of 0.25. The mean weight was 47.8 kilograms with a p-value of 0.17. And the mean height was 130.5 centimeters with a p-value of 0.84. The most common peripheral IV active site was the antecubital. For those that did have extravasation, again, they had significantly higher peak pressure, and the p-value was 0.01, and the flow rate, an increased significantly higher flow rate, and also had a p-value of 0.001. Like I said, earlier studies reported incidence of extravasation with power injectors between 0.1 and 0.9%. So that does fall in line with the 0.7% within this study to show the incidence of extravasation using power injectors. So one takeaway from this study was that they did try to show that the overall belief that younger children were at a higher risk for extravasation, just due to the integrity of the skin and the smaller vein size. So the findings of this study initially was showing that is not the case. If you have kids 11 years of age, you would expect that to occur usually more typically in the younger neonates or younger children. Same for the mean and height, the height and weight. But the p-values were not significant in these cases. So you can't really say that this study showed that the risk of extravasation doesn't typically occur with children. But it did show that they had significant p-values indicating that extravasation did occur with higher peak pressures and flow rates. So again, as far as when you're using the power injectors, you want to kind of monitor the pressure and flow rate using those injectors to prevent the current extravasation. So here are my references. So I hope you learned a lot from this presentation and kind of a better understanding of what extravasation is and how to treat it. So like then here's my references if you'd like to look into further about treatment extravasation. If you have any questions, be free to answer them.